Hello dear students, I'm Dr. Anupama Chowdhry Devgan, the Physiology faculty at Allen Next. Since 2005, I have been teaching physiology and mentoring students preparing for the NEET PG, INI CET and FMG exams in different cities across the country. And what I've come to realize is that PYQs are today the cornerstone of your preparation. Your exam preparation will be incomplete if you do not go through your PYQs at least 2 to 3 times. And especially just before the exams, it's a very good idea to go through these PYQs as your last minute revision. PYQs will touch upon all the important topics as well as far as your physiology preparation is concerned. So let's start with the 2018 PYQ. So the first question here is, maximum secretion of IGF is from which of the following? Now, what is IGF? This is insulin-like growth factor 1. Now, growth hormone secreted from the anterior pituitary, this acts on the liver and liver will secrete IGF-1. Insulin-like growth factor 1. And this IGF-1 secretion is maximum in the adolescent age group. And this IGF-1 is responsible for the growth spurt at puberty. So the answer to this question is going to be the liver. Liver is the source of IGF-1. And what you have to remember is that IGF-1 is responsible for the growth of the epiphyseal plate cartilage, and it causes an increase in the length of long bones, and that is what is responsible for the growth spurt at puberty. What is this growth spurt at puberty? This happened to all of us in that age group between 12 to 16 years. Suddenly we shot up in height, and that is because of the growth of the epiphyseal plate cartilage, which increase the length of long bones, and this is primarily due to IGF-1. So the source of IGF-1 becomes the liver. Next, let's see. Glucose is transported across the intestinal lumen via which of the following mechanisms? Now, when you look at the absorption of glucose, this is an enterocyte. Enterocyte has a brush border towards the lumen, and on the basal side is the blood vessel. So glucose has to be absorbed from the lumen and transported into the blood. So how does that happen? Now, on the luminal side, there is a sodium glucose co-transport. This is an example of secondary active co-transport. This is also known as SGLT, sodium glucose linked transport. Now, the subtype, the protein which is present in the intestinal epithelial cell, it's called SGLT1. You have a similar SGLT in the PCT, and the SGLT in the PCT of the kidney is SGLT2, but in the intestinal epithelial cell, it is SGLT1. Remember, there is one intestine, so SGLT1. There are 2 kidneys, so SGLT2. Now, once glucose enters the cell, it leaves the basal side via what are known as glucose transporters, GLUT. And GLUT is an example of facilitated diffusion. Now, which is the GLUT which is most abundant in the enterocyte? And that is GLUT2. So that means there are 2 processes which are involved in the absorption of glucose. There is the secondary active co-transport on the luminal side, and there is the facilitated diffusion on the basal side. So which is the correct answer? Which one should I choose? If both are given in the options, which one should I choose? My answer here in that case will be secondary active co-transport. this is going to be my answer, because remember, secondary active co-transport is responsible for glucose moving from the lumen into the cell. Once it enters the cell, then it goes into the blood via facilitated diffusion. So which is a better answer out of the two? Secondary active co-transport. So let's see this here. This says glucose is transported across the intestinal lumen via secondary active co-transport or facilitated diffusion. My answer is secondary active co-transport. And there is an important clinical aspect to this. Oral rehydration solution has both sodium and glucose. For absorption of sodium, glucose must be present, and that is why oral rehydration solution has got both electrolytes as well as glucose. Just a brief look at what we have just discussed. For the absorption of glucose and galactose, SGLT1 and GLUT2. But for the absorption of fructose, it's a little different. Fructose is absorbed by facilitated diffusion on both sides, luminal as well as the basal side. So absorption of glucose and galactose by secondary active co-transport and facilitated diffusion, but the absorption of fructose is by a specific fructose transporter, which is known as GLUT5, and GLUT is an example of facilitated diffusion. Let's have a look at the next question. Now it says all of the following statements about countercurrent multiplier are true except. Now which is the countercurrent multiplier? Countercurrent multiplier is the loop of Henle. And the loop of Henle has a thin segment and a descending thin segment and thick ascending limb. Now, what is option A? Option A says descending limb is highly permeable to water, and this is true. The movement of water occurs from the descending thin segment. The descending thin segment and thick ascending limb have got different permeabilities. The descending segment is permeable to water. Thick ascending limb is permeable to sodium chloride and potassium, which is also true. What happens in the thick ascending limb is movement of Na+, K+, and 2Cl-. It is called Na+, K+, 2Cl- co-transport, which is an example of secondary active co-transport. C option says descending thin limb is impermeable to water, which is incorrect. I've just told you that the descending thin segment is permeable to water. Descending thin segment has what is known as aquaporin 1. What is aquaporin? Aquaporin are water channels. So descending thin segment has got aquaporin 1 on the luminal side, which makes it permeable to water. Descending limb is moderately permeable to urea. This is also true. And let me explain that to you. But of course, the answer to this question is, which is an incorrect statement, that is C. Let me try and explain how is the descending limb permeable to urea. Basically, let us just have a look at how the kidney handles urea. So when I look at the nephron, this is the PCT, this is the descending thin segment, the thick ascending limb, the DCT, and the collecting duct. Now, as far as urea is concerned, urea is a freely filtered substance. Now, urea absorption is by facilitated diffusion. There are urea transporters which are present. So the PCT is permeable to urea, and almost 40 to 50% of urea is absorbed in the PCT. When I say absorb, means it re-enters into the blood. And this movement of urea is passive. It is with the help of urea transporters. When a segment of the nephron has the presence of urea transporters, that means it is permeable to urea. So half of urea has got absorbed in the PCT. Urea now moves through the descending thin segment, thick ascending limb, DCT, cortical collecting duct, and now it comes to the medullary collecting duct. Now, medullary collecting duct is permeable to urea. It has got urea transporters. Which are the urea transporters present here? They are called UTA1 and UTA3. Just subtypes of urea transporters. So now, remember, by the time urea reaches the medullary collecting duct, there is an increase in the urea concentration. Now, why is there an increase in the urea concentration? Let's try and understand that. See, what has happened as the fluid moves through the tubule? There was absorption of urea here and also absorption of water in the PCT. In the descending thin segment, more water got absorbed. So what will happen to the concentration of urea? Increases. As we move ahead, when it comes to the collecting duct, in the cortical collecting duct, there is more absorption of water. Outer medullary collecting duct, more absorption of water. So by the time urea reaches especially the inner medullary collecting duct, there is an increase in the urea concentration. Water has been continuously absorbed in the nephron. So a high urea concentration means urea can now move from higher to lower concentration. There is less urea in the medullary interstitium as compared to the lumen of the medullary collecting duct. And medullary collecting duct is permeable to urea. There are urea transporters present. So urea starts moving from the medullary collecting duct into the medullary interstitium. And about 20% of the filtered urea is excreted in the urine. But urea has moved into the interstitium. What is the advantage of urea in the interstitium? It increases the medullary interstitial osmolality. It makes the medullary interstitium highly concentrated. And what is the advantage of a highly concentrated medullary interstitium? It helps us to produce a concentrated urine. And movement of urea from the medullary collecting duct into the interstitium, does it require any energy? No. The movement is by facilitated diffusion, which is passive transport. Now, once urea is in the interstitium, it increases the medullary interstitial osmolality. Now, the descending thin segment or the thin segment of the nephron is also permeable to urea. It also has the presence of urea transporters. So when the urea concentration increases in the medullary interstitium, some urea now goes back into the nephron through the thin segment. Now this urea will move into the thick ascending limb, into the DCT, into the cortical collecting duct, and now it reaches the medullary collecting duct. Some urea will come into the interstitium, some is excreted out. When the urea concentration in the interstitium increases, it now re-enters into the nephron, and at the same time, more urea is coming from the PCT. Together, they move through the thick ascending limb DCT, cortical collecting duct, reach the medullary collecting duct from here into the interstitium, back into the nephron. This is known as urea cycling. And what is the advantage of urea cycling? It increases the medullary interstitial osmolality. And what is the advantage of a high medullary osmolality, medullary interstitial osmolality? Is it helps us to produce a concentrated urine. Now, a common question which I'm asked is, if the thin segment is permeable to urea, then why does urea now not go from the lumen of the thin segment into the interstitium? Why is it only from the medullary collecting duct into the interstitium? And the reason is, movement of urea is passive from higher to lower concentration. So even though you've got urea transporters in this segment, but the concentration of urea is higher in the interstitium as compared to the tubular lumen. So movement of urea will be from medullary collecting duct, higher concentration, to the interstitium, and then into the thin segment. and not in the opposite direction. So that means my next important point, and that is which segments of the nephron are permeable to urea. Which are the segments which are permeable to urea? And that is the PCT, the descending thin segment, and the medullary collecting duct. And which are the ones which are impermeable to urea? Impermeable to urea will be thick ascending limb, DCT, and the cortical collecting duct. These are impermeable to urea. So this is urea cycling. Next, C wave in the JVP is caused by which of the following? Now, as far as JVP is concerned, now JVP, you will always see it on the right side. Why do we see the JVP on the right side? Because the right internal jugular vein is in direct communication with the right atrium. So all the right atrial pressure changes will be reflected in the right internal jugular vein, and we call that JVP, jugular venous pulse. Now, the JVP has got multiple positive and multiple negative waves. When I say positive wave, that means it is a outwardly directed wave. It is called a positive wave, that is outwardly directed wave. And which are the positive waves? You've got A wave, C wave, V. And which are the negative waves? These are inwardly directed waves, that is X descent and the Y descent. So let's understand what are these due to. A is due to atrial contraction, A wave. C wave is due to bulging of the closed tricuspid valve into the right atrium during isovolumetric contraction phase. See, in the isovolumetric contraction phase, right ventricle is contracting as a closed chamber. When the right ventricular pressure increases, it causes the closed tricuspid valve to bulge into the right atrium. When it bulges into the right atrium, it will increase the right atrial pressure, which is seen as a positive wave on the JVP. After the C wave, you've got what is known as the X descent. What is X descent? It is a negative wave. X descent is due to a downward movement of the closed tricuspid valve during the phase of ejection. Then you get the next positive wave, which is the V wave. And V wave is due to venous filling of the right atrium just before opening of the tricuspid valve. After the V wave, when the tricuspid valve opens, blood moves from the right atrium into the right ventricle. That gives us the Y descent. So let's see flow of blood from left ventricle to aorta. Now, remember, JVP does not reflect the left ventricular changes. It reflects the right atrial changes. So this is not an option for the JVP. Passive filling of the atria will be responsible for the V wave just before opening of the tricuspid valve. So answer to this question, C wave is caused by bulging of the AV valve or the tricuspid valve into the right atrium during isovolumetric contraction phase. Now, JVP is a very popular or very commonly asked topic, so we should be absolutely clear about what are these different waves due to. Again, let's have a look at these different waves. I told you A wave is due to atrial contraction. C wave is due to bulging of the closed tricuspid valve into the right atrium during isovolumetric contraction phase. X descent, downward pull of the closed tricuspid valve into the right ventricle during the phase of ejection. V wave, due to venous filling of the right atrium just before opening of the tricuspid valve. This is the point where the tricuspid valve opens. Flow of blood from the right atrium into the right ventricle causes the Y descent. This is the Y descent here. And then atrial contraction in the second rapid filling phase, will produce the A wave of JVP. So A, C, V are the positive waves, X descent and Y descent are the negative waves. Now, when will I get a prominent A wave? A prominent A wave like this. When do I get a prominent A wave? That means now the right atrium is contracting against a greater resistance. When does the right atrium encounter a greater resistance? When the tricuspid valve is stenosed or there is a right ventricular hypertrophy. So a prominent A wave will be in reduced right ventricular compliance. Right ventricular hypertrophy will produce decreased right ventricular compliance and a tricuspid stenosis. Then you have something known as a cannon A wave, very large A wave. Let's try and understand what can produce a cannon A wave. Remember, when the right atrium contracts, the tricuspid valve is open, blood goes from the right atrium into the right ventricle. This is what happens in the second rapid filling phase. Atrial contraction is responsible for the last 25 to 30% of the filling. Now, what is a cannon A wave? Now, if the right atrium contracts and the tricuspid valve is closed, so the entire force exerted by the right atrium will be now reflected in the right internal jugular vein, and you see a very large A wave like a cannon. When does this happen? When does the right atrium contract against a closed tricuspid valve? That is called atrioventricular dissociation, what is known as junctional rhythm. So atrioventricular dissociation will cause cannon A waves. That means atrial contraction is against a closed tricuspid valve. Which condition will produce absent A waves? Atrial fibrillation. Let's look at the next clinical aspect of the JVP. Now, in tricuspid regurgitation, what do we expect? In tricuspid regurgitation, because the tricuspid valve is incompetent, there is now a backflow of blood from the right ventricle into the right atrium. So V wave is going to be accentuated. A large V wave is going to be seen. And the Y descent, and again, because the tricuspid valve is incompetent, we see a large V wave. And blood will rapidly go back into the right ventricle. So we see a rapid Y descent. In severe tricuspid regurgitation, we find that the V wave merges with the C wave. And that is known as JVP is ventricularized. What happens to the Y descent in tricuspid stenosis? It is prolonged or it is blunted. This is the Y descent. It is going to be prolonged or blunted in tricuspid stenosis. If the valve is stenosed, then Y descent was due to flow of blood from the right atrium into the right ventricle. That is going to be much slower. So it is prolonged and blunted. Let's look at the next question. Now this says, which of the following does not cause an increase in aldosterone? Aldosterone is secreted by what is known as the zona glomerulosa of the adrenal cortex. Now, what causes increase in aldosterone? Aldosterone, two very important stimuli for aldosterone secretion, and that is the renin-angiotensin aldosterone. And if there is an increase in the plasma potassium level. Plasma increase in dietary intake of potassium increases the plasma potassium level, and that directly increases aldosterone secretion, because what are the actions of aldosterone? Aldosterone will increase the sodium reabsorption. It increases the potassium secretion, and it also increases the H+ secretion. Extremely important to understand this. How much is the normal plasma potassium level? 3.5 to 5 millimoles or milliequivalents per liter. If I increase my dietary intake of potassium, how can I increase my dietary intake of potassium? Which are the foods which are rich in potassium? Bananas, coconut water. So supposing I decide to have 3 or 4 nariyal panis, I will immediately increase my plasma potassium level. The moment there is an increase in plasma potassium level, it directly increases aldosterone so that aldosterone can increase the loss of potassium in urine and the plasma potassium level will come back to normal. Remember, increase in potassium levels more than 5 can have disastrous consequences. Hyperkalemia is something which is not desirable at all. Increase in plasma potassium directly increases aldosterone, but aldosterone can also be increased by the renin-angiotensin-aldosterone system. So question says, which of the following does not cause an increase? Increased serum sodium will not cause, in fact, it is a decreased serum sodium. Decreased sodium hyponatremia is associated with decrease in ECF volume, and that will increase the renin secretion and therefore aldosterone. Increased serum potassium, definitely. ACTH secretion. Now remember, ACTH does not directly affect aldosterone secretion. Aldosterone is primarily being controlled by renin-angiotensin-aldosterone, but ACTH increases steroidogenesis. Of course, ACTH increases the secretion of glucocorticoids and androgens, but it can also increase aldosterone, not directly, but by increasing steroidogenesis. So yes, increase ACTH. Decreased ECF volume definitely will increase the renin secretion. Hypovolemia, hemorrhage, hypotension, hyponatremia are extremely important stimuli for increasing renin secretion. So we can see this over here, which are the stimuli which increase renin. Renin is from the JG cells, juxtaglomerular cells. Hypovolemia due to any cause, hemorrhage, hyponatremia, dehydration, anything which decreases the renal afferent arteriolar pressure, even a renal artery stenosis. Increased sympathetic discharge. Why increased sympathetic discharge? Because JG cells have got beta receptors. So sympathetic discharge can directly affect the JG cells. Then liver cirrhosis, congestive cardiac failure. These can also increase renin secretion, because what happens in cirrhosis and congestive cardiac failure is edema. There is edema which is present, and that decreases the effective circulating blood volume. And this is responsible for increase in aldosterone secretion. In fact, cirrhosis and CCF, these are two very important causes of secondary hyperaldosteronism. Let's see the next question. It says, if VQ ratio approaches infinity, it means which of the following? Remember, it is not equal to infinity. It is saying approaching infinity. See, VQ ratio will be equal to infinity if Q is equal to 0. Perfusion is 0. Anything divided by 0, the quotient is infinity. If VQ ratio approaches infinity, what does that mean? That means ventilation is much more than the perfusion. Ventilation is relatively much more. Ventilation is in excess of the perfusion, either because of overventilation or underperfusion. Approaching infinity means perfusion is definitely much less as compared to ventilation. Ventilation is relatively much more. what would be the best answer here? No O2 is absorbed, no CO2 is released. This is if perfusion is 0. But if perfusion is 0, VQ ratio has to be equal to infinity. If there is a pulmonary artery obstruction, perfusion will be 0. VQ ratio will be equal to infinity. Surfactant is not produced. Surfactant is not produced will reduce the ventilation. Alveolar collapse will start happening. PO2 is maximum and PCO2 is minimum. This is the best answer. You must understand, when I say VQ ratio approaches infinity, that means ventilation is much, much more than the perfusion. So that means very little blood flow, but which is very well ventilated. And if ventilation is much more than the perfusion, what will happen to the PO2 levels? PO2 levels will increase and CO2 will reduce. So high PO2 and low PCO2. Please understand, if the question said VQ ratio is equal to infinity, then my options A and B would have been correct. But since the key word here is approaching infinity would mean that it is not yet equal to infinity, but it is close to infinity. So that means ventilation is much more than the perfusion. In other words, very little blood flow, but very well ventilated. So high PO2 and less PCO2. You can see this in this particular graph here. This shows you PO2 on the x-axis and the PCO2 on the y-axis. These are both in millimeters of mercury. When VQ ratio is equal to 1, we find that the PO2 is equal to 100 millimeters of mercury and PCO2 is equal to 40 millimeters of mercury. As you can see over here, 100 and PCO2 is 40. If VQ ratio becomes more than 1, there is an increase in the PO2 level and decrease in the PCO2 level. Like I've just explained to you, ventilation is in excess of the perfusion. How does a ratio become more than 1? Numerator is more than the denominator. If perfusion is equal to 0, VQ ratio is equal to infinity, there is no exchange. This is seen in pulmonary embolism. The composition of air will be equal to dead space air. See, what is dead space air? In dead space, there is no exchange. What is the definition of dead space? Volume of air which does not participate in respiratory exchange. So in dead space, there is no respiratory exchange. So when VQ ratio is equal to infinity, the composition of air in those areas of the lungs will be similar to dead space air. And dead space air has a very high PO2 of 150 and PCO2 is generally less than 5. So 3 millimeters of mercury approximately. On the other hand, if VQ ratio becomes less than 1, now ventilation is less than the perfusion. So there will be a decrease in the PO2 and increase in the PCO2. When does VQ ratio become equal to 0? If ventilation is 0. And when is ventilation 0? When you have a foreign body in the bronchus or the trachea, foreign body in the airways. Ventilation is equal to 0. If ventilation is equal to 0, what will be the composition of the alveolar air? It will be similar to venous blood. No ventilation is taking place. This is also known as intrapulmonary shunting. And what is that going to be? The PO2 will be equal to 40 millimeters of mercury and PCO2 will be equal to 45, which is similar to venous blood. So once again, when the VQ ratio is equal to 1, which is a normal VQ ratio, we find a PO2 of 100 and a PCO2 of 40. If the VQ ratio increases, more ventilation is compared to perfusion, what do we find? There is an increase in PO2, decrease in PCO2. When the VQ ratio is equal to infinity, for example, in pulmonary embolism, the composition of air will be similar to dead space air, PO2 of 150 and PCO2 of 3 millimeters of mercury. On the other hand, if the VQ ratio reduces, that means ventilation is less than the perfusion, we find a decrease in PO2 and an increase in the PCO2. When the VQ ratio is equal to 0, that means ventilation is 0. For example, foreign body. We find the composition of air will be similar to venous blood. And what is the composition of venous blood? PO2 is 40 and PCO2 is 45. Let's have a look at the next question. Release of synaptic vesicles from the presynaptic terminals is inhibited by which of the following? Now, what happens? The presynaptic neuron and the postsynaptic neuron. When the action potential reaches the terminal of the presynaptic neuron, there are voltage-gated calcium channels which will open up and there is an influx of calcium. Once calcium enters into the cells, these contents of the vesicles here are exocytosed. These neurotransmitters will move across the synaptic cleft. There are receptors on the postsynaptic membrane, and that is how transmission occurs from one neuron to the other. Now, question says, how can I prevent the release of these synaptic vesicles? What is essential for exocytosis is presence of calcium. So, if I can prevent the calcium influx, there is no way that the contents of the vesicles can be exocytosed. Preventing influx of calcium will prevent the release of this neurotransmitter. Let's look at the next question. It says, proprioceptors for joint and position sense are which of the following? Now, proprioceptors are always slowly adapting receptors. Which are the proprioceptors? You have joint capsule receptors, which are meant for position sense, joint sense and position sense. The others are muscle spindles, which are meant for muscle length or stretch, and the Golgi tendon organs, which detect muscle tension. So these are your receptors for joint and position sense, and these are slowly adapting receptors. So these were your NEET PG 2018 questions. If you have any queries regarding these questions, please feel free to email me at drAnupamaDevgan@gmail. Hope you found this session useful. These are some very important topics, and remember to go through them before the exams as well. Thank you very much.